And so now instead of thinking of this as buckets, I need your attention for just 20 minutes, and we're going to talk about this like a game, a high school football game. And our visiting team, our rival team, is the Retrovirals. So how they normally come to the game is they pull up in their GP 120 bus, and they come over and bind a CCR5 or CXCR4. Now, the door on that bus is called GP 140, and that's what they use for getting into our game. So whenever that fuses on in, we got the Retrovirons, and they're going to have their own coach called the reverse transcriptase. And then that's going to come in and make cDNA and the viral RNA. Now then, they're going to need to use an integrase to bring that on in and put it on a football field. And we don't want that. We don't want them disrespecting our football field, because when they do that, we can't get them out. It's in there forever. And so then, if they did that, they're going to be able to be transcribed, and they're going to have their own regulatory proteins, structural proteins, and then they're going to have a pole gene that assembles it all into this bud here, and then puts it back on out to where they can go and beat other teams at the high school football season. So our team, to stop all this from happening, has got 6 players. It's got coaches, it's got a first string, it's got second strings, and then we got a couple tattletales that are trying to stop the game from playing. But we like them. That's good. We want tattletales to stop this game from happening. So the coaches are what we call NRTIs. The reason why they're coaches is because you always got to have a coach in the game. You can't have a game without a coach. And then our first strings are always going to be added to the game. And then sometimes the first strings got hurt, or they need to go into the locker room for a bit so that we can do some tests on them to see if they can play in the game, so we pull out the second strings. And then the third strings, well, we don't have to go with that. So going over, we're always going to start with 2 coaches in the game and a first stringer. And that's what we got going on over here. Now, one of these coaches, ABC, is allergic to grass. And so they can only play in games with artificial grass. And so you always got to check the football field to see if you can play with ABC. We'll get more to ABC in a minute, but ABC stands for a back of ear. Now, if the incoming retroviral team is kind of low on players, we don't want to overwhelm them. We want to be sportsmanlike. So we're just going to go with 2 deals here, DTG and 3TC. And that's only if the opposing team ain't got many players and their hepatitis B negative. But if we got the history of our first string class here, the INSTIs, the integrase inhibitors, if we got a history of them, they've been playing safe, but sometimes, they got a history of needing to get checked for stuff. We're going to go on and we're going to use the second strings here so that they can go to the locker room, get checked out, make sure they're nice and ready to play the game. And so what that is that you're checking for resistance to the integrase strand transfer inhibitors, and you're going to go with a
protease.
We want to be sportsmanlike, and so if there ain't many players coming over from the Retrovirons, we're just going to use 2 of our players. We're going to use one of our coaches, and we're going to use one of our first stringers.
There you go.
Now, sometimes our first stringers need to get tested. Make sure they ain't hurt. But we need to keep on playing this game so that we don't lose. So we're going to go ahead and throw in our second stringers, the protease inhibitors. And so as those test results on our first stringers are pending, we'll go ahead and throw in a DRV and a TDF, TAI, and a FTC and 3TC, or 3TC.
Yep. Very good. All right, and now we're going to go through the roster of all of our players. So our first player that we're going to talk about is Marovic.
I'll go through the first stringers first.
Yeah. So let's introduce our coaches first. So the first one we got is FTC. It is a C analog that's going to go in. Actually, I should be down here. So our coaches fall under the NRTI.
I can record it for you.
Yeah, I want to do that. Okay. So this is going to fall under the NRTI. These guys are going to lack the 3' OH group, which if we go back over here, if they're not able to polymerize and grow that strand, the retrovirals are not going to be able to replicate and play the game. So that's a form of competitive inhibition on the retrotranscriptase enzyme. So generally, there are some effects with the NRTIs, mainly due to mitochondrial toxicity with stuff like lactic acid syndrome, peripheral neuropathy, pancreatitis, some anemia, granulocytopenia, and some myopathies. So with that,
get back into the accent. Keep the accent going.
You can't really do that the whole time. Okay, and then we also got the AZTs, which is kind of like it was one of the oldest ARTs developed. This is the only ART with an IV route. It is a thymidine analog, so it's going to go up and act like thymidine, but it doesn't, again, have the 3HOH group to polymerize stuff, so it kind of stops the retrovirals in their tracks, if you will. Some other stuff to note about AZT, this is not a first line or first choice to use as one of your coaches.
Old coach.
It's one of your older coaches, meaning they're not as potent as they used to be, and they got increased more side effects, so they don't coach as well, and a lot more stuff goes wrong. This form of this ART, this AZT, this is still useful though for HDLV1 and 2. And something else is this also goes through hepatic glucuronidation for metabolism. Then the next coach that we also have is the D4T. These guys are similar to our AZT coaches, but these again are kind of rarely used due to their side effects. So again, this is one of our older coaches that we got. So this particular NRTI has the strongest association with lipodystrophy and fat wasting. So again, that's the reason why we don't use it. Now, one of our main head coaches that we've had for a while that we do like to use is FTC, and this one is a cytosine analog, and it does kind of the same function as our other two that we talked about before. This can be treated we can use this as treatment for HPV alongside with TAF or TDF. And as a general principle, you do not want to use any of these drugs as monotherapy. There's a lot of different ways we can tackle the other team, so it's best just not to limit ourselves to one different way of playing them.
You got to have a coach on the field and a coach in the box.
These guys, they get a long intracellular half-life, and they're mostly pretty much the same once they are excreted. They're also one of the least toxic and one of the mainly used ARTs used in therapy. However, one thing that's to note about this is with the prolonged use, we do see some hyperpigmentation of skin, but other than that, it's generally well tolerated. Next, we got 3TC. Again, this is one of our newer coaches. That's kind of our other main coach that we use a lot. This one can also be used for HPV, but again, we don't want to use monotherapy. The reason for that, between 3TC and FTC, they got a low barrier of resistance, so meaning it's not going to take that much for them, for the retrovirals to become resistant to them. So, we also can use this in naive patients with a lower viral load. We often use that in dual therapy with DTG, which we talked about a little bit before. And again, there's no real major side effects with 3TC, so again, that's part of the reason why we also use it a lot. Again, like FTC is unchanged when it's excreted, and this helps increase the long-term effects of other ARTs. Next coach that we got is abicavir. This is ABC, and this is a G analog, and this is also the only guanine analog we have amongst our coaches.
That's the only coach allergic to grass, guanine.
Yes, and this is the only one that is allergic to the grass we talked about. The reason we said that was because you cannot use ABC as coach if your patient has HLA-B 5701 or also is positive for HPV. Now, if you do use it on a patient who does have HLA-B 5701, there's a very strong association with aberrant TNF release. Long story short, that's a bad deal. We also want to avoid this in coronary artery disease because it's also associated with hyperlipidemia and cardiovascular events. This is also not a CYP substrate, so but it is metabolized via dehydrogenases, and it is also conjugated with glucuronide. Our next two are pretty much the same. They just wear different jackets. They're kind of like twins. So the first one is DTF. These guys are analogs for adenine. Now, when I said jackets, I meant that they take the form of prodrugs. They weren't prodrugs that have low bioavailability. They can be used in HPV treatment, and they also HIV can also get resistant in the same way to them with a K65R mutation within the reverse transcriptase. Some side effects with both of these, there's substantial nephrotoxicity with acute tubular necrosis or leading to Fanconi syndrome. So we want to avoid using this coach if our GFR is below 60. Some other stuff that goes on is we're going to gradually lose bone density at first, but as time goes on, that bone density is going to stabilize. Now the other twin, TAF, also an adenine analog and a prodrug, it also can be used to treat HPV. Again, it's the same mutation. This one we want to avoid. This one we really want our patients to have a GFR above 30 if we're going to give it to them. This one has an interesting effect. Whenever you lower the dosage for this one, the plasma concentration can lower. Actually, that should be increased. Whenever you increase the dosage on this one, the plasma concentration will go down, but the intracellular concentration of a metabolite of this drug is actually going to go up and actually help keep the drug going. There's less renal toxicity than the other twin with TAF compared to TDF. This one is associated with the most amount of weight gain amongst the coaches, but it's still less than compared to the star players. The last coach that we have on our roster is didanosine. It's also an adenine analog. It's also a prodrug, and this one has been, for the most part, replaced by less toxic antiretrovirals. This one can also be used in treating HTLV1 infections. All right, and so next up, we're going to go ahead and introduce our third stringers, just in order. So our third stringers is going to be our NNRTIs, or non-nucleotide reverse transcriptase inhibitors. These guys are going to non-competitively inhibit reverse transcriptase by binding to a different region than the active site like our coaches do. These guys are going to bind the P66 subunit. When they bind the P66 subunit, that denatures the reverse transcriptase to where they can't do what they normally do. So, generally speaking, we only want to do this with HIV1 only. HIV2 inherently is resistant to this form of this, and again, partially why they're not our first choice for therapy. For the most part, these guys also induce CYP 450, which leads to a lot of drug-on-drug interactions. Again, not making them a great first line. HIV can also get resistance by a mutation in the P66 subunit of reverse transcriptase. And also, if you are going to use these guys, you definitely want them to have some support, so you must combine them with other classes. Generally speaking, like I said, we do not want to use monotherapy when treating HIV. Next up, the first third stringer that we got is MPV. This is the first third stringer that we got. This was the first one that we found. This was the first of its class to be invented. One of the main things to be noted about this one is because this one induces CYP3A4, oral contraceptives tend to go down faster, and so an alternative form of birth control is going to be needed for patients that are taking it. This has been replaced for the most part, yet it's one of the more resistant NNRTIs. Now we also have EFV. This one's also one of our more resistant NNRTIs. This one, you need to take this drug on an empty stomach. The reason being is because food inhibits that absorption, so you need to take it on an empty stomach. Again, this one also induces CYP3A4, also 2B6 and 2C19. So again, if you're on birth control, you're going to need an alternate form if you're taking this drug. Now, some side effects to note about this one. We get some CNS toxicity and psychiatric side effects that you definitely want to monitor. Kind of a hallmark one is vivid dreams or nightmares. Something else is QTC prolongation with the heart. That's a big deal, so you definitely want to keep that in mind. Another thing is this used to be considered teratogenic. However, recent studies have kind of shown maybe not the case, but for all intents and purposes, I'm considering this still to be teratogenic. Now, next up, we got ETR. This works great in treatment experienced patients that are still positive for HIV. Some interesting things about this is that it still works even when other NNRTIs have become, well, when HIV has become resistant to other NNRTIs. That is probably contributed to molecular flexibility, but again, the mechanism is still not entirely sure. This one also induces CYP3A4, so that's going to give us a wide range of drug-on-drug interactions. Now, the notable side effects here for ETR, we got a rash. This rash often resolves, but sometimes they open up the Ark of the Covenant and their face falls off. This is Steven Johnson syndrome. So keep that in mind. The other thing that can happen, that's equally as horrible if you're the oldest, is the immune reconstitution syndrome. What that is with HIV, it's an immunosuppressive disease. So if we start treating HIV and the immune system wakes back up, it's going to see the mess that that HIV has made, and it's going to wake up and be angry. It's going to be just like mom coming back from a long night's work, and she's going to ask, why is the house such a mess? And then the oldest is going to get blamed for it. So next up, we got RPV. Again, this is used to treat treatment-experienced patients with HIV. These guys, they are resistant to this particular mutation, K103N, which affects all of these guys, but they can still be affected by multiple other mutations. This one is going to need some food. It's really hungry. So the reason for that is you need to be able to lower the pH. So if you're treating a patient that's wanting to use this medication, you need to make sure they're not taking PPIs. PPIs are your proton pump inhibitors, and if you have the proton pump inhibitors, your stomach is not able to make as much acid, and we want a lower pH, meaning more acidic environment. Now, there is some other stuff with new treatments with neuromuscular every 4 weeks, along with Govicestat, which we'll get to. Now, some more side effects for RPV. They tend to occur more often in children than adults. There are some CNS effects such as depression and headaches, and also rash, and just like EFV, we also get QT prolongation. Excuse me. So our last NNRTI is DOR. Now, this one is used to treat naive patients with HIV. Or the other treatment option here is for patients that are trying to switch to, that have been on a stable and effective ART regimen and are wanting to switch to this particular therapy, which generally is generally pretty good. This DOR, this is the best the third string has got. It can be taken with or without food, even though it is metabolized by CYP but it doesn't really induce it, so we don't get significant drug-on-drug interactions. And if you get resistance to EFV over here, you can then use DOR. Now, if you get DOR resistance, you can then fall back onto ETR. The other thing that can happen with the side effects is, again, you can get the immune reconstitution syndrome. Next up, we got our first stringers, our INSTIs, or our integrase inhibitors. The other way some people like to phrase this is strand transfer inhibitors. This is our best 1+ active agent that we can give to a patient who's just contracted HIV. Henceforth, we already have our two. If we go back to the backbone of our treatments, we have two coaches that are always in the game. These guys are our star players. These are first stringers. These are starters. These guys are who we want to be playing. First one that we got is RAL. Kind of like what I was saying before, these guys are able to decrease the plasma VRNA way faster than our third stringers over here was able to. Some other things to note: polyvalent cations are going to inhibit its absorption. Right now, it is not available in single tablet forms, so patients will have to take multiple drugs to get the proper. Not multiple drugs, but multiple tablets to get the medications that they need. These guys are eliminated both fecally and through the urine. They can be unchanged, or they could have gone through glucuronidation. Some other side effects include a potential skin rash or hypersensitivity reaction, and also the immune reconstitution syndrome. We can get myopathy and rhabdomyolysis. We can also have worsening suicide ideations or depression with that. So our next star player is we got EVG. This is often paired with some others. The reason for that is because it's metabolized by CYP3A4, so it needs a boost.
Steroids.
Yeah, this is the guy that just, no matter what he does, he can't get that strong, but he still needs to be able to play. So he decides he needs a little boost. He needs a little sports performance, if you know what I mean. So this is also similar to DTG, which is our next player. Our next player, DTG. This guy's got a high genetic barrier to HIV getting resistance against it. It's first line for infections in naive adults, and it is primarily metabolized by UGR1A1 glucuronidation. This guy can decrease the RNA load way faster than EFV, which we remember was kind of gave everybody nightmares. So the main treatment here is we can give patients DTG with either 3-TC or with ABC. Now remember, ABC can't play on artificial turf. These are available as a fixed dose combo, so everything that the patient needs is generally in one tablet or pill. Side effects, they're going to be similar to RAL, so the potential rash, hypersensitivity, the rhabdomyolysis, the CNS effects. Some other stuff is we get increased liver enzymes and potential weight gain. This drug has also been associated with neural tube defects, so we definitely want to avoid that with pregnancy. The next one that we got, this guy we recruited him out of Beverly Hills. He's very expensive. He drives around a Ferrari, and his dad is a multi-billionaire. It's the only reason he's on the team. This guy, again, can clear the viral RNA much faster than EFV. We got a similar genetic barrier to resistance, just like DTG. And this guy is glucuronidation by UGT1A1 and CYP3A4 metabolized. Yet this one has fewer drug-on-drug interactions. It is only really affected by CYP and UGT1A1 when there's potent dual inhibitors going on. This guy is more readily absorbed and more soluble than the other star players amongst his roster. Side effects, it's generally well tolerated, and there is some association with weight gain, but yeah. And so then our last player that we got is CAB. Now CAB is kind of special because it's the new form of PrEP, which is pre-exposure prophylaxis. What's nice about this is there's only one injection that they have to get per month, IM, and it's usually paired with RPV. RPV was where's RPV? RPV, yeah, so it's paired with RPV, and there's a minimal association with weight gain. All right, and so and then coming down the stretch, we got a couple of our second stringers, so these are the guys that are going to come in if we can't use for star players. These are protease inhibitors.
Why wouldn't we be able to use the star players?
Hmm?
Why wouldn't we be able to use the star players? Because one of them was using steroids. They got tested.
Yes, so that's the problem. So either this guy or this guy, they've been seen together using some stuff that they probably shouldn't be doing. So in order to follow the state's guidelines as far as their drug policy goes, these guys gotta get drug tested. So they gotta get drug tested before the game can start. So meaning we gotta check and see whether HIV's got the resistance to this with PrEP being used. Until that time, these are backups that are actually going to be playing. So we have protease inhibitors. These guys will cleave the GAG and POL precursors, and that will allow HIV to get fully assembled and then go on to other fields and just wreak havoc like they normally do. So the other thing is, these protease inhibitors are going to competitively inhibit a spartyl protease, a homodimer. That homodimer is going to cleave the N-terminal prolines. And then once that happens, then the structural proteins for capsid, they're ready to be assembled, and HIV is even closer to ready to budding out, go into the next field, wreaking havoc. Some other stuff about this. The clearance for the protease inhibitors is strictly by the hepatic oxygenation carried out by CYP3A4 again. And so just like our star player over here, they're going to need a boost, ritonavir, which is the most potent CYP inhibitor. And fun story was ritonavir, who's now one of our assistant coaches, used to play for this team, but we found out that he was a better coach than he was a player. So all of these protease inhibitors, they are substrates for MDR1, which can contribute to drug resistance.
What else do you call that, MDR1?
Glycoprotein 1. And kind of like we said before, the speed of resistance for all of these, and then RTIs or third stringers, they're going to develop the quickest. HIV is going to develop the quickest resistance against them. Next up is our PIs. They're going to be kind of in the middle, and then NRTIs, they're going to have the slowest onset of resistance amongst all the ART therapies. So, first one that we got is SQV or saquinavir. This was the first protease inhibitor developed. It is not used anymore in most first world countries just because there's more and more backups to pick from. This one's got poor bioavailability. It's associated with nausea, vomiting, diarrhea, and lipid dystrophy. The next one we got is IBD. Again, this is no longer recommended. It was kind of the second one that was made. However, something really relevant to know about this is this has the unique side effects of crystalluria or renal stones. That tends to come up on boards. So next up, we got DRV. This was also used in PrEP. This is metabolized by CYP3A4. So again, it is boosted just like the others with either Cobastat or ritonavir, our assistant coaches. This is currently the best choice protease inhibitor. Is preferred over the boosted ATV, which we'll get to next. Some side effects, this acts sort of like a sulfa drug. So this can cross-react and lead to hypersensitivities and a rash. We get increased transaminases and hyperlipidemia. There's an increased cardiovascular risk, and this is greater than ATV, which we're going to talk about next. So ATV is an azopeptide. There's decreased absorption with acid-decreasing therapy, so proton pump inhibitors. This is the current PI choice that comes. This is the current protease inhibitor choice alongside with either the R or the C boost. This is treated in naive patients or treatment-experienced patients that have ended up developing that need a protease inhibitor replacement. Next up, for some side effects with this guy, we get increased unconjugated bilirubin. This is not hepatitis related. The other stuff we can get is cholelithiasis or nephrolithiasis. And probably the most notable one to be aware of is this ATV can cause a PR prolongation.
How do you say yellow in Spanish? Amarillo, atazanavir.
I didn't know that. Next up, our last second string that we got is LOP. LOP also needs a boost for R, and it's only available as that. Now, the interesting thing about this one is it often works after the other PIs have failed, i.e. HIV has gotten resistance to them. This has been, for the most part, supplanted by DRV and ATV as far as treatment options go. Now, last I kind of mentioned them a little bit, but these are assistant coaches. So we got ritonavir. Like I mentioned before, this used to be a protease inhibitor.
Well, these are really more like the assistant coaches part-time that are giving out steroids that we were talking about over here.
Yes. So this one is only used to inhibit CYP proteins. So this guy's going to boost other drugs or give them out to the other players. Now, that's going to maintain their plasma levels, keep them high and keep them effective. Some side effects with ritonavir: you get some flushing, you get some rash, you get some GI stuff. Now, this also, with it being a CYP inhibitor, opens the door to a lot of different drug-on-drug interactions, depending on what the patient's taking, what else the patient is taking. Now, the other assistant coach that we got, the part-time volunteer, we got the cobastat. Now, this guy is going to boost ATV and DRV. ATV and DRV. Okay. Yeah, this guy specifically going to do that. This is not a replacement for ritonavir or R.
Because it has no protease activity.
It has no protease activity. This is primarily fecally excreted, and again, some side effects include that because it's a CYP inhibitor, this opens up the door to a lot of different drug-on-drug interactions.
You want to do a recap in the accent of
All right, so just to briefly recap again. So, say we have a patient who comes in with no history of CAB use or PrEP use. We're just going to go ahead and give them one of our star players, two of our coaches. So, there's a lot that we can pick from these. These are just 3 examples. We mentioned ABC because, again, you can only play an artificial turf, so don't give ABC to someone who's HLAB. Now, again, say the O team, they don't have as many players, and we still want to be sportsmanlike, so it's still a competitive game that everybody can enjoy. We're going to only use a dual therapy in low viral loads and with HBV negative patients. Now, say the opposite is true, where we have a patient with a history of PrEP use. When that happens, PrEP, as I mentioned down here, this was the new PrEP. It's CAB, which is good. They were taking action, they were protecting themselves, which is all good. However, the other team might have seen them ahead of time. They say like, oh, we know how to beat this team because we can get past one of their star players. So if they have the history of that game film on them, the other thing that might also have happened at the same time is CAB might be hurt. So we need them to get tested. And until we can get those results back, we're going to bring in our second stringers, mainly DRV. TAF, TDF, the twins, FTC, or 3TC. There is plenty to pick from, but again, this is just an example. But the idea is we got to use the backups first before the starters can go back in.